introduce Dr. Ashish Jha, who I had the privilege of meeting maybe a year and a half ago. And every once in a while you meet somebody who is just a wonderful combination of incredibly talented, incredibly smart, and incredibly nice. Ashish is somebody who does everything exceptionally well. So he's a doctor who's in practice and sees patients in connection with the VA and knows of what he speaks when he's navigating the healthcare system. The way I got to know Ashish was in the context of an organization he runs at Harvard called the Harvard Global Health Institute that does incredibly meaningful and important work in terms of promoting healthcare for the poorest all over the world and looking at the very, very big picture and important questions. But on top of all of those things, Ashish is one of the foremost experts on US healthcare policy. And in particular on the question of how we use evidence in an effective way to make sure that the system works as well as it should. So without further ado, I'd like to turn it over to Dr. Ashish Jha.
Oops. Can you guys hear me okay? I was going to say, how does one live up to that billing? Not well. So here is, so thank you, Quentin, for that very generous introduction. We have about 35, 40 minutes together, and you are giving me your most precious commodity, which is your time, and I want to make sure I use your time wisely. I have a bunch of slides, and I could go through all the slides and make a bunch of points, but I'm hoping that we actually have a discussion. I realize the room is a little long and not the easiest, but as far as I'm concerned, I think this will be a lot more fun for me, and I think more interesting for you if we make this as interactive as possible, okay? And so what I'm going to do is I'm going to lay out some obvious stuff. I'm going to take 2 minutes to do a little level setting, remind us what the kind of problems are that we're trying to address, and then get into what I think has been the standard thinking about why we have these problems in healthcare. I'm going to argue that I sort of think of it a little differently. Then I'm going to share a journey that we've been on for the last 10, 15 years on how I've been trying to reform the US healthcare delivery system. That's going to be the more depressing part of the talk because I'm going to argue that like we haven't quite been doing it right. But then I'm very optimistic about the future, and my optimism has not diminished in the last 9 days in terms of healthcare delivery reform, other issues we can talk about. And I'll spend a good chunk of time on that, and then we'll wrap up. But as I said, discussion to the extent that we can. So the talk is sort of entitled kind of innovation in healthcare delivery and why do we need it. And the reason we need it is these two things, right? If you look at the US healthcare system, the costs are way too high. The population outcomes are really poor compared to what they should be. You guys know this, but I'll just put up the slides. National health expenditures, if you look at it, what's been happening. 2.6 trillion, by the way, is the mark at which the Affordable Care Act was passed, and 3.2 trillion is where we are. These are just big numbers. They don't really mean much to any of us because I have no idea what $3.2 trillion actually looks like or what it means. The one thing I will say is, however you feel about the Affordable Care Act, the notion that it has had a big impact either in bending the cost curve or accelerating the cost curve is hard to see in this data. Right? And so if you're a big fan, you say, boy, it's really made a big difference on costs. I'm not seeing it. If you're a big critic, you say the costs have exploded under the ACA. I'm not seeing it. So, there's lots of other ways of looking at the data per capita, et cetera. And I think it has not had much of an effect. But there is a very high cost of high-cost healthcare. And that is a point that I think is worth making, and I want to spend 1 minute on that. This is Massachusetts spending on healthcare between 2001 and 2010, right? Our Commonwealth, if you look at what the spending in Massachusetts has been across a range of things, so it'll be hard to see the bottom, but I'll tell you guys what we're seeing. Mental health spending in Massachusetts in real dollars declined 22% between 2001 and 2010. Public health spending declined 31%. Education, which used to be the biggest line item in the Massachusetts budget, declined 12%. Infrastructure spending down 14%, law and public safety down 13%, local aid to struggling cities and towns down 51%. And it begs the question, where did all that money go? and it all went into healthcare. So the point of this slide is not spending on healthcare is bad. I'm a doctor. I think spending money on healthcare is great, right? We should be spending twice as much on healthcare. Why do we need education anyway? Kidding. But the point is that we should understand that there is a cost to spending money on healthcare, right? Massachusetts did Massachusetts health reform. That was terrific. I'm a big fan. But that money came from somewhere. And every time we make investments in healthcare, we ask the question, should we spend money on healthcare? That's fine. But we should also ask the question, and where are we getting this money from? Right? And if this is a good social policy trade-off, that's great. If it's not, it's fine. That's a value judgment. We should at least be aware of this. And I find that the discussion on health policy is often in isolation, focus on just the 37% and whether we got good value out of it. We don't think about the other stuff. Okay. And then everybody kind of knows this, but if you look at like how we do compared to all these other countries, what you can see is we actually started off, we're yellow by the way, we started off kind of in the middle of the pack, and over the years we have managed to distinguish ourselves as sort of the lowest performer when it comes to life expectancy among high-income countries. So lots of spending, not great outcomes. So the question is, why do we have these problems, right? Why are we in a situation where we spend a lot of money on healthcare and don't have great outcomes? If you go to Washington, D.C., and you grab random health policy experts and you start asking them these questions, you're going to get answers like this. You're going to say, we pay for volume, not value. We need to pay for value. No, and by the way, these are standard answers, don't make them wrong. They're just the standard answers. We have a sick care system, not a healthcare system. We pay for care when people are sick, but if we could just pay for prevention, we'd save a whole bunch of money. I'm happy to, by the way, dig into any of these, because these are important concepts, and I'm not going to treat them with any of the seriousness that they deserve, because we could spend the next 2 hours going through this. Greed and profit, certainly if you're on the left of the political aisle, people love talking to the fact that we have a for-profit system, and even though 80% of hospitals are nonprofit, that's somehow really the driver. Of course, if you're on the right side of the political aisle, you bring up government regulations. The list of kind of culprits of our healthcare system is long, but these are some of the kind of big picture things that you hear, okay? Questions, thoughts on any of that? All seem pretty straightforward. This was the level setting part, right? This is the kind of bring everybody up to speed on, I think, where we have been. So here is where I tend to sort of disagree a little bit with, I think, policy folks. Those things are all important and they all have different levels. But in my mind, when I think about the real issue, I think of things like this. Here's a picture of Denver General Hospital in the year 1909, okay? And here is a picture from a hospital today. If you look at it, one's in color, one's in black and white. I understand there are differences. It actually doesn't look that different. If you took a doctor from 2016 and plunked him or her into a hospital from 1940 or 1920 or 1909, they'd actually navigate themselves through pretty quickly and pretty well, right? That, to me, is a problem. Because the care that we deliver has changed radically since 1909. But how we deliver the care, the delivery system underlying it, has not. And there is nothing else we do in our lives that you could go back 100 years ago, or 130 years ago, or 20 years ago, and say, yeah, we did it exactly the same way, right? Almost nothing else. But healthcare is sort of 21st century medicine in 19th century delivery models. And that, in my mind, is the problem. And during that time, and I kind of alluded to this, care has gotten way more complex. Here is a slide that I actually had no idea that Lucian Leap was going to be here. And I actually attribute the concept behind this solution, and I'll just make the point, and then I'll say what I learned from Lucian on this. Lucian Leap, who's really been the foremost force on driving patient safety and thinking about how to improve the safety of our healthcare system. One of the points he makes is when he trained as a pediatric surgeon, the number of drugs that he needed to keep in his head for treating patients was relatively very small. And now we have 12,000 drugs have been approved. I walk around the wards in the hospital, and the idea that somehow I can keep hundreds and hundreds and hundreds of medications in my head and manage all of this stuff, it's just beyond the capacity of humans. Healthcare has gotten dramatically more complex. It's one of my favorite quotes. Medicine used to be simple, ineffective, and relatively safe. It is now complex, effective, and potentially dangerous. Not potentially dangerous. Dangerous, right? This is true. This is true. And this is the issue around delivery models, that we have a way of delivering healthcare that looks like it was designed for a time when we had a handful of drugs, a handful of treatments. They were relatively easy to do. One quick side story, if you had a heart attack 30 years ago, there were probably 1 or 2 treatments that you got. You spent 3-4 weeks in the hospital, mostly in a quiet room. Today, you spend 3 to 4 days in the hospital. You get literally dozens and dozens of interventions done to you. The good news is mortality for heart attack has fallen from about 25% to about 10%. The bad news is the complexity is something that we're still trying to manage using very old systems. Okay. So before I move on to the next part, this is coming up is the sort of depressing part of the talk. Questions, thoughts on that as a basic premise of this? Yes?
For the non-clinicians, can you provide a little example of how the way we navigate healthcare has not changed in the last 120 years?
Sure. So for most people, if you get sick, you have a couple of options. You can call your doctor, try to squeeze in a visit, or you can go to the emergency department, right? 50 years ago, if you got sick, you could call your doctor, or you could try to go to the emergency department. Like, yes, we have a little bit more now, urgent care centers, and we have a little bit around minute clinics. They're still pretty small, right? But as a patient, the system doesn't look dramatically different. At least that's my perspective. In relation to when you think about how we do anything else, from simple things like how we take money out of the bank to how we interact with each other. This talk that I'm giving, the way it was set up, these guys emailed me. We went back and forth electronically. We had a conference call that I took on a cell phone. I mean, it's a very different world, and none of that is all that interesting, except you look at healthcare and you think, this can't be the way we do it. And the answer is yes, it is. Okay. Other questions or thoughts on that? Yes?
My perception is the increase in specialization, right? 100 years ago, one doctor would know everything and do everything, and now we do rely much more on.
Yeah. No, that's a great point. So the individual doctor's training, knowledge, and actually I think of that as actually in some ways part of the same story, which is that complexity, the 12,000 drugs. I can't keep track of 12,000 drugs. And so we have taken me as a general internist and split people like me up into lots of buckets and tried to deal with it by specializing humans. There's a great line. Tom Lee, who's a close colleague and friend, often likes to say, we've done this journey of specialization is such that we've got people to know more and more about less and less to a point where we now have people who know everything about nothing. It's a great line. But there is this element of first we had cardiologists, then we had interventional cardiologists. Now we have people who are echo specialists who look at the right heart only. And these are doctors, and that's all they do. And they're amazing at it, right? But the delivery system that underlies how they deliver care is still pretty stuck. Yes?
Well, I guess this is the hard question. Why is that? I mean, other industries have changed more, you say. The only other thing that seems a little bit the same when I think about it is K through 12 education.
Yes.
And so I guess my question, which is, a tough one, is why?
Yeah. So I think a big part of it is payment models, right? We pay for healthcare in a certain way. And if you pay for healthcare in a certain way, then you're going to only be able to deliver the kind of care that is going to get reimbursed in a certain way. So payment models do matter a lot. If you decide tomorrow that you're going to develop a company, there's a lot of companies doing this out there, that have totally new ways of interacting with patients, if people are all paying through insurance and the insurance companies don't want to pay that, your company's not going to do very well. Right? So that, I think, has locked us into a very specific delivery model. And that actually is the third. So the next part is about how we try to tweak within the current payment model, and it hasn't worked. And then the last part of this talk is how we've now actually, I think we're on a journey towards rethinking the payment model altogether. Okay. I'm going to keep going unless there's one more burning question. Yes, gentleman back there.
So do you see this as an American phenomenon?
No.
Compared to those other?
No. I see this as a global phenomenon. And the issues around safety, effectiveness, costs, even costs, where we are 2x everybody else, If you walk in, I'll give you the one random side story. About 2 years ago, I was visiting a rural province in China, small province, 80 million people. Right. And I was speaking to the guy who runs the health system essentially for the entire province. I mean, sort of. And I said to him, what are the most pressing healthcare system, health delivery problems, health system problems that you are facing? And he said, I think of my problems in 3 groups: cost, quality, and access. And I thought, I was like, you're pulling my leg. That's what people in DC say, and that's what people in Ottawa say, and that's what people in London say, and that's what people in Beijing say, right? So it is interesting. Of course, how those things manifest themselves vary, but it is interesting that that's where we are. Okay, I'm gonna keep going. So what has our strategy been to date on thinking about this stuff? What we have done is focus on discrete clinical events. What do I mean by that? The doctor's office, the emergency department, the hospitalization. We have had an approach of measurement. We're going to improve value, we're going to improve care by measuring stuff that happens in that clinical encounter. Some of those measures are often evidence-based. We're going to use science, but they're often not. And that's because over the last 20 years, there's been this very strong desire, I felt it, that we need to be measuring more in healthcare. And sometimes when you don't have good measures, you make them up. But those things can have consequences. And then what we have done generally is, so measurement is one part of it, but measuring doesn't unto itself do that much. And yes, I know there's a Hawthorne effect, but the truth is you need to do something with those measures. And so we have applied these policies of public reporting, pay for performance. And I'll just give, for those of you guys not steeped in this, the notion here is really very straightforward, right? What we've done is said, okay, what we're going to do is we're going to measure the doctor or the hospital or the emergency department, and then we're going to make that information public. And that'll motivate patients to pick good doctors or hospitals, and it'll motivate doctors and providers to get better. It's public reporting. And then the second part has been pay for performance. And that's really straightforward. We're going to pay you more if you do better. We're going to pay you less if you don't do well. Okay? And I would say those have been the 2 of the dominant strategies until about 2-3 years ago. And so I'm going from about 2000 until about 2012, 2013. And I'm just going to sort of show you a little bit of how that's worked out. So let's talk about public reporting. I got to give you the answer here. There are literally 2-3 dozen studies on this. I'm not going to go through a comprehensive review of all the studies. I picked a couple. I promise you they're not cherry picking. They are representative, and I'm happy to get into more details. So here's a study that we just published 2 months ago, looking at hospital outcomes in an era when we were reporting publicly versus when we were not. And basically, if you look at what's been happening, and there is a phenomenon here of mortality rates have been getting better, and I'm happy to talk about why that is. But what you basically see is things have been getting better when public reporting kicks in. Let me just put this up. Before public reporting kicked in, mortality rates were falling across a range of cardiopulmonary conditions about 0.25% per quarter, or about 1% per year. And after public reporting kicked in, it actually slowed down. I'm actually not going to try to tell you that public reporting has been bad for improving outcomes, but it's very hard to look at these data and say public reporting has been a big home run. And literally, as I said, there are dozens of studies like this, dozens of studies like this that basically show that while things have generally been getting better, public reporting has not had much of an impact. And I feel very comfortable making the point, public reporting as done today, transparency as done today, and I bolded that because somebody's going to come after me and say, well, you don't believe in public reporting. It's not an issue of believing in public reporting. It's just as we're doing it is not leading to better patient outcomes. Okay? Let me show you one more set of slides like this, and then I'll stop and see what questions people have. So some people are like, well, yeah, transparency is not that powerful. What if we start tying payment to it? And here's a paper we published about 6 months ago looking at national mortality rates for a bunch of conditions after pay for performance kicked in. You'll see it's a very similar format. Things have still been getting better over time. This is the onset of pay for performance nationally. And what you see basically is things were, again, there's been literally dozens of studies on pay for performance, dozens of studies on public reporting. And I would argue this too, that pay for performance as we are doing it today is not improving patient outcomes. Okay? And so let me just make the final slide on this part. What we have done in the last 10 years was focus on discrete interactions with the healthcare system. We've done performance measurement, public reporting, pay for performance, and it has not been a home run. I'm going to stop there. There's a lot I threw at you, but the concept is this. What we did was we said, okay, we deliver healthcare in a certain way, right? Doctor visits, ER visits, hospitals. Let's go look at each one of them. Let's figure out how to measure performance. And I think we have lots of problems in how we measure performance. Then let's make that stuff public and let's put incentives on all of it, and surely that'll make things better. And it's turned out not so much. You did see in all of those slides, in both of those slides, that things have been getting better. Mortality rates, for instance, have been falling. I could show you data on central line infections, and those have been coming down. There are areas where we've had real improvement. And so the question is, what's that about? And what that is about is the march of science, in my mind. We've gotten better. We've gotten better at diagnosis. We've gotten better at treatments. We have new drugs, new surgeries. Surgeries have gotten safer. It is in the clinical context that stuff is getting better. And that's good. There's a little bit of evidence that how we apply the clinical trait is also getting better. Specialty societies, Society for Thoracic Surgery, American Heart Association, have done a lot in engaging clinicians on the front lines, and that too has driven some of the improvements. But I think there's very little reason to think that the national policy efforts that we have made have been a big hit in terms of really making a big difference. Okay. I'm going to now pivot. So that was a depressing part. Hopefully you're not all too depressed. I'm going to pivot now to talking about where we go next. Questions, thoughts on our kind of national strategy? Yes, sir.
It hasn't been a resounding success.
Yeah, to say the least.
The health outcomes. How come the push has been so strong? Or continues to be?
Yeah, so two things. First of all, there's a little bit of like faith versus evidence. There's often a clash. And I think that a lot of this stuff has been faith-based. And I don't actually think that's a problem in the sense that if you got a bunch of health policy experts together in 2006, 2008 and said, what do y'all think we ought to be doing? They would have said transparency and incentives. That's not unreasonable, right? Totally reasonable. I think there are two issues. One is that the execution hasn't been very good. And again, I'm happy to get into what I mean by that. The incentives have been small. The measures haven't been great, et cetera. But the other part is it's hard for people to change mental models, right? And it's hard to change mental models on this. And so there's a variety of reasons why people have kind of stuck with the, but I see it getting better, but they don't look at studies that have controls. I mean, there's an interesting debate in the health policy world. I'll talk a bit more about this, but I'm bringing it up now, is like, do you need randomized controlled trials for this kind of stuff? And it's interesting because most of the times I'm on the side of saying, you may not need RCTs, but you need to do something more than just look at 5 data points and say it's getting better, because a lot of other stuff is happening in the world, right? And so the level of evidence that we have accepted, so there's a national value-based purchasing program. It was essentially created based on an evaluation of a demonstration program where the evaluation didn't have controls. I don't want to forget RCTs here, right? We're just saying, how about temporal trends? So I think the level of evidence that we have accepted, and I think when you live based on faith, you understand why the level of evidence. I have faith, for instance, I believe that my children are brilliant. And so the level of evidence I need to confirm that is very, very low. And the amount of evidence I need for you to convince me that they are not brilliant, is very high. Right? That's an extreme example of a point. Okay. Where are we going next? I think where we're going next is new care delivery models. And this I am more optimistic about. But by the way, I temper my own optimism by saying I was pretty optimistic about the last bunch of stuff too. One of the things I say when I have given versions of this talk is, I've been studying public reporting and pay for performance for about 10 years. I did not set out in my career to say, let's find something that's not going to work and spend 10 years studying it. Because that's depressing, right? That is not the career I had asked for. I started studying because I thought these were important. This is what we were doing nationally, and I believed that they were going to have an impact. And it turned out that they haven't had much of an impact. Okay, new care delivery models. There's a whole bunch out there. I want to talk about a couple. One is accountable care organizations. I'm sure you guys have all heard about ACOs. Actually, just by quick hands, how many people have not heard about ACOs, don't know what an ACO is? Okay, only a couple. I'll give you there's lots of formal definitions. Here's a very informal one. It's a group of providers, doctors, hospitals, who take full responsibility for the costs and outcomes of a population, right? So a group of providers who say, yep, assign us a group of patients, we will take care of that population. Oops, sorry, I keep doing this. We will manage their costs, we will manage their outcomes. The other big model that has gotten a lot of interest from a policy point of view is bundle payments, and is bundling payments based on episodes of care. Just as a quick side point, this is not a new concept. We, in fact, started this in the 80s. In the 1980s, we used to pay hospital care very piecemeal. Every test got a certain reimbursement, every visit by a doctor, every single thing was reimbursed separately. And then in the 80s, Medicare said, no more of that. We're going to give you a single bundled payment for the entire hospitalization. It's called the DRG payment scheme, and we've been doing it for 30 years. And people think it's been pretty successful at curtailing costs. And so now what we're doing with the bundle payment initiative is going from just the hospitalization out. We're going to say we're going to bundle 30 days or 90 days worth of services. And one of the things that I think that people at CMS, at Medicare, are particularly good at is coming up with acronyms. So all of these things have acronyms. So I already told you about ACOs that are part of the ACA, but now we have BPCI and CCJR. I've spelled out episode payment models. I should have just left EPM for AMI and CABG. The point is, these are all essentially, acronyms are fun. They're all essentially different ways of bundling a set of healthcare services. And there is more coming, and actually let me make a quick point about this. All of these are ways of bundling a set of healthcare services and saying to doctors and hospitals, you are responsible for the whole thing. And here's the key point on this. The more coming is a point I put into my slides about 2 weeks ago. And then last week I thought about whether that point should come out, and I decided not to. Because when I think about what's going to happen under the new administration, by the way, take everything I say with a massive grain of salt, because nobody knows, including Donald Trump, what they're going to do next on healthcare. But I think the stuff that's going to mostly change around is on insurance and exchanges and Medicaid expansion. I think the delivery system stuff has relatively bipartisan support. Where there's a little bit of pushback is on how mandatory to be, how aggressive to be. Though my general take is we should be more mandatory and more aggressive. Okay. Who is driving these changes? Right now, it's this agency at Medicare called CMMI. There's a whole bunch of initiatives that they're doing. They get basically $1 billion a year for 10 years. That's what the Affordable Care Act gave them. They have funded 76 new programs, many of them in early stages. I have about 7 minutes left, so I'm going to go a little fast here. Here's one slide that I want to put up. Medicare, CMS, spent about $1 trillion, is spending about $1 trillion this year. Between all the Medicare, Medicaid, all the different programs, right? This covers a good over 100 million Americans. That's a lot of money. And if you ask the question, how much money is it spending? Here's the Innovation Center at 0.2%. It's really probably actually closer to 0.1%. And if you ask the question, how much money does it spend overall on measurement and thinking about generating value from the other $999 billion that it's spending, it's not 1%. It's barely 1/10 of 1%. Right? We have a serious problem with how much money we spend on the current care delivery models and how much money we spend on building new models, trying out new stuff, and studying it. And most industries, most organizations think about 3, 5, 10% on this stuff. We're not at 1. We're barely at 1/10 of 1%. Okay. Questions on any of that? Yes, back there.
So, how is the ACO model any different than the PMPM we're paying MCOs right now for individuals? Like, we haven't seen savings really on that. How is ACOs going to save us from bending the cost curve?
Yeah, PMPM is per member per month. For those of you who, no, it's fine. But I'm assuming not everybody knows that. Look, I think, hold. How are things going? Here's some data on bundle payments. This is basically arguing that, again, there's a lot of data here, and I want to be fast about this. Comparison hospitals, BPCI hospitals, baseline during the intervention period. So this is a difference model. It's better analysis, right? The savings seem to be a little bit better under bundle payments than under control hospitals. If you look at shared savings, Medicare's ACO program, here's 2 points I want to make. The CMS's internal evaluation suggested they actually lost a little bit of money. But a much better evaluation of these ACO programs comes from a guy named Michael McWilliams here at Harvard, who published an analysis in October of 2016, a month ago, basically found about 0.7% net savings. Is that a home run? No. Is that progress? I think so. And how are ACOs doing it? By thinking about the entire episode of all the care they're trying to deliver and figuring out what can they get rid of. Okay? So my take on ACOs is it's really early days, or a few years in, we got to give them more time. The question people push back at me, so how much time do you want to give them? They're about 4 years in. You want to give them 5, 10. There is going to be a time when we say the savings have not been huge. But I'm optimistic that we're starting to make some progress on this. I don't know to what extent I've answered your question. Mostly, I think I punted, but yes.
Awesome presentation.
Should be on. Nope. Should not.
Awesome presentation.
Thank you. I'm not done yet.
All right. As a driver, I've noticed that you haven't mentioned the patient as a driver of these services.
Yes.
I've noticed that you haven't talked about the other social determinants
Yes.
that creates negative outcomes, like
Yes.
environmental factors.
Yes.
That creates a sickness in the body. For instance, if you live near hazardous waste
Yeah.
facility,
Yeah.
like, and so could you elaborate on the consequences of the environment as well as people being a part of it?
I absolutely will, and I'll take a minute and do it in justice because it's actually a really important set of issues that require a lot more time than that. Those are incredibly important issues, and certainly everything from patient engagement and patient activation and patient expectations play a very important role. And the social determinants are very important, very complicated. There's overwhelming evidence, right, that where you live, what your education level is, what your job is, what your housing situation is, all that has a profound effect on health, on spending. The harder questions are what do we do about that and how do we manage that and how much of that is the responsibility of the healthcare system versus kind of society at large. And those are value questions that I think we're struggling with. The new care models actually try to get the healthcare system to think about that a little bit. Because maybe if the ACO can invest a little bit in housing and save a bunch of healthcare dollars, now they have an incentive to do that. The old delivery systems never had an incentive to do that. And so the argument from policymakers is there's $3.2 trillion in here in this healthcare system. What if we get them motivated to think about those issues in exactly the ways that you have articulated? I would say it's a tough business. It's hard. These hospitals are not geared up to do that, but it'll be interesting to see to what extent they can. All right. I have 3 minutes. Okay, let me actually, I'm going to skip through some of the other data. Summary of where we are today. I think we have new care models are starting to get going and getting tested, ACOs, bundled payments, comprehensive primary care, which I did not talk about, but it's sort of that PM model that somebody described where we're starting to give money to primary care physicians, more money and saying really think about taking good care of the patient. There are other models. And the big point is, remember I said the old stuff, not a home run? Early innings. Just staying with the baseball analogy for a minute here. Really early, and so declaring victory, declaring losses at this stage in the game is, I think, very problematic because we're just trying out a bunch of stuff. Some perspective on all of this. You guys all recognize the ATM. People love talking about ATMs when they talk about healthcare because whenever we talk about data sharing, they're like, I can go to Germany and pull out my ATM card and pull out cash. I go across the street from the Brigham to the Beth Israel and they don't have my medical record. What is the deal? That's a different conversation, which I'm happy to have at another time. But here's one slide that I find very interesting, which is looking at diffusion of ATM adoption. ATMs really came out in the early 70s, and it took about 15, 20 years for them to take off. Right? Like, this is a simple, easy technology that we all think, like, this is a no-brainer. This stuff is expensive in terms of, like, they cause disruption. It takes a while. So the point on that is not give this all 20 years, let's invite me back in 20 years and I think we'll have made real progress. Because I would argue we don't have 20 years to wait on healthcare innovation and delivery innovation. We have to move faster. I think the problem right now is we have too little innovation in two forms. That makes no sense, so let me explain what I mean by that. Two ways. Too little innovation in the sense that the number of stuff we're trying, I think, and the variations in which we're trying it is, I think, inadequate. Bundle payments, ACOs. I want to see 18 other efforts of trying to think about how to change the way we deliver healthcare. And the second form of too little innovation is if you look at the CMMI, if you look at these innovation models, they have like a success rate of 80, 90%, depending on how you want to measure success. Part of that is we don't do good evaluations. Part of it is we're too cautious about this. If you look at, and I hate bringing this up, but if you look at like places like Silicon Valley and kind of their investments, like 10% hit rate is awesome, right? 20% hit rate is awesome. And in healthcare, we are very cautious about this stuff. I think until we start seeing more failures, I'm going to actually feel like we're not doing enough. Second is our speed of our evaluations, I think, is too slow. We put in an innovation model. 3 years later, we gather the data and publish the results. Then we fight about it for 2 years in terms of whether we're actually making progress or not. And then we change the model, right? Got to iterate much more quickly. And then the last point, and I kind of skipped over this earlier, our analyses on how we do this. And this is where, as I said, I find myself in between two camps. On one side of the aisle, there are people who really think we need to be doing more rigorous randomized controlled trials of these interventions. There's another camp that says, I can feel the improvement. And we got to be somewhere in between. I'm fine to go closer to the RCTs, but if you're going to do the evaluation, you got to have real valid measures. You got to have controls. You got to look at time trends. There's a bunch of basic stuff that we got to do. And the pushback from people in the policy world is, you're too academic. And my pushback is, I have no idea what you just did, whether it made a difference or not. And before we go scaling it and making tens of thousands of other doctors change the way they practice medicine, you want to have a little bit of evidence that it's working. I am over time, so I'm going to just, I've made a lot of these points. I think we need to measure what we want, hold providers accountable, but I think we just need to kind of innovate a lot more. Final thoughts. I think we're on an enormously important journey, and I'm very optimistic about how the next 5, 10 years goes. New care models represent, I think, an important opportunity to make care better. We're not going to get there without experimentation, but I said we need to do these more, better, faster. Yes, I want all three, more, better, and faster. We're spending $3.2 trillion on healthcare. I think we can get it. I don't think the problem is there's not enough money in the system. Anyway, I'm gonna stop because I am over time. I don't know if I have like maybe a minute for one more question, or do you want me to? One more question. Thank you guys all for listening. One last question, sir.
Sorry, I want to take you back almost to your first slide with the elephant in the room, which is if all of these other countries, OECD countries, some I've lived in, have far better outcomes, far lower price, why don't we just copy models, whichever one we choose, instead of us trying to figure out, well, maybe we can tweak this for 0.07% of the next decade.
Yeah, great point. And can I take the next 45 minutes? Is that okay? In 45 seconds, 3 things. One is there is no model that works in every country. The English model looks different from the Swiss model, which looks different from the French model, which looks different from the German model. Second is if you think about what differentiates us from them in terms of spending, it's all price. We don't do twice as much healthcare. We just pay twice as much for healthcare. Price is a particular problem of the US, where if you're on the left, you say it's really straightforward, price regulation, tight price negotiating. If you're on the right, you say we need efficient markets. We have figured out how to do the worst of both. Inefficient markets with a weak price setter. That's us. Third is there is a whole bunch of social issues that go into the kind of outcomes that other OECD countries achieve. And we're going to have to think a lot about kind of our social contract, where's social spending fit into all of this before we're going to achieve their kind of outcomes. So we're going to be tweaking the 0.7%. All right, sorry to go over, guys. Thank you all very much.